Hello, everyone. Welcome to week number 2 of your outpatient billing and reimbursement course. Hopefully, you are settled into the course and you've started to really think about your CCS and CCSP exams that you will take in August. And so this week, we're getting into revenue management, revenue cycle management. And as we enter this week, I want you to think about the fact that at the end of the day, healthcare is a business. And the number one expense that hospitals have, healthcare systems have, is paying us. And so a lot of times people say, well, healthcare is so expensive. But then also in that same breath, we say, hey, some of us working in healthcare are not being paid enough. So I want you to really take your personal opinion out of the picture and really understand everything that goes into running an organization of this size. So, chapter 3, and just like last week, I will do one lecture for chapter 3 and then one lecture for chapter 4. But chapter 3 introduces revenue cycle management. And I think you'll find, oh, there are some terms that we're seeing here that we learned in the inpatient billing and reimbursement course. Because keep in mind, we use two different books for each class, and there is some overlap. So, our objectives for this week, and again, let me just remind you this lecture is no substitution for reading the chapter. So, you should be able to define the key terms related to revenue management, explain the characteristics of revenue management, be able to differentiate between how new and established patients are managed. And this, interestingly enough, ties into your CPT class for week number 2, because we're talking about evaluation and management in that particular course. You also are going to learn about the encounter form and the charge master, processing of an insurance claim. And the objective says from patient appointment to claim submission. Think of this as from patient to payment. Next, explain how to post charges to patient accounts, and then summarize the methods of monitoring and auditing for revenue management. So, revenue management really has several objectives, but chiefly among them is that we really want this work to be accurate. We want to optimize and we want it to be timely. And let me explain one thing about timely. So, remember, I said that for healthcare organizations, the largest expense that they have is the salary and benefits. And when you work for 2 weeks, you want a paycheck, right? That following week. Well, when we provide services to patients, we submit a claim form to the insurance company, but we are not necessarily getting paid a week later or 2 weeks later. Yet and still, we have to meet payroll each and every payday. So I want to lay that out there, because as a person who's going to work in this space, you want to ensure that the work is accurate, that it is timely, and that we are paid for the services that are rendered, which means we have to capture them. So, revenue management or revenue cycle management is basically just making sure that we have a healthy revenue cycle, that we are able to stay viable, meaning we are able to stay open, right? And so, when we stay open, we can continue to care for patients in the communities that they work, live, and play. As it relates to this process, and I call it from patient to payment, the process really begins In an inpatient setting, before the patient even gets admitted, right? Let's say the patient is in the emergency room, right? We start the process of collecting information. And then if the patient does have to be admitted to the hospital, we have all sorts of testing and medical necessity to support why that patient needs to be admitted. And so the process begins prior to that inpatient admission as a result of that work. And in some cases, it requires pre authorization from the insurance company. And then it really ends once the patient leaves and we submit the claim and we post to the patient's account what we got paid for the insurance company. And when it applies, we are, letting the patient know what they are responsible for as well. All right, so revenue cycle management and the accounting department, let me just tell you from an accounting perspective, they're looking at accounts payable and accounts receivable. Accounts payable is what they have to pay out, accounts receivable is what we are receiving. So it begins right at that appointment schedule, right? We are expecting to receive services that are provided. There are many names for revenue cycle management. Sometimes they call it accounts receivable management, but basically it's about us again paying and getting paid. Oh, let me just add this. When I think about paying, we are paying salary and benefits, but we're also paying for the lights and the heat and the air conditioner and the supplies and the equipment. And so when you think about your own personal household, a lot of times we owe more than what we bring in. And some hospitals actually fall into that predicament as well. And that's why it's so important for us to make sure, as coders and billers, that we are capturing what was actually done. So this is a visual from the textbook that summarizes the patient to payment. That's what I call it, patient to payment cycle. And notice it begins with that appointment. The patient shows up, they are registered, the services are provided, they are documented, and then the services are coded. Um, the claim form is submitted. When the claim goes to the insurance company, they say, yes, they're going to pay us. No, they're not going to pay us. Maybe they pay us, right? In either case, whatever their decision is, we post that to our system. We may need to resubmit claims. We may need to appeal the claim. And then again, if the patient has a cost sharing provision in their plan, like insurance company pays 80%, patient pays 20%. We are billing the patient for that work. And then if the patient doesn't bill us, we are sending them to collections and um, still attempting to collect that money. The other thing you should know, and you can Google this, lots of companies have to write off charges every year for, let's see, what do we call them? uncollectible um uncollectible money, right? Money that we provided the service but we cannot collect the payment. But let me just keep reminding you of this, they still got to pay you every 2 weeks. All right, so new patients, when new patients enter our facility, we and this is via the patient access department. We make sure the patient isn't in our system. We get a copy of their insurance card and their driver's license, front and back of both documents. And then we identify, who their insurance company is. We have technology today where we can verify what services are covered. We also want to identify like who's responsible for the bill. So if it's a kid, their parent is responsible for the bill. And sometimes the patients have more than one insurance, right? So they have insurance by the mother and insurance by the father. And then there's what is known as the birthday rule that comes into play, that's discussed in the book. But then also, and this is something that patients don't often understand, is whether or not we are participating in that patient's insurance plan or not. I think oftentimes these are the questions that patients don't ask. They just say, "Do you take my insurance?" Right? But the really question is, okay, you take my insurance, but to what extent? We may take your insurance, but it may be accepted at a lower rate. So let me just give an example. We take your insurance will pay 80, you pay 20. We take your insurance, but your insurance will pay 40%, you pay 60%. That's why it is important for patients to actually know their benefits. And most patients don't know what is covered. And then they come to our facilities and they're really upset with us because we have the privilege of telling them, well, your insurance doesn't cover XYZ. And it's not us that's not covering it, it is the insurance. So when we have a new patient, and something I want to call out in the book makes a distinction between new and established patients, because with an established patient, we just have to um, verify that everything is the same. We need to re-verify that everything is the same, because let's just face it, things change. People get different phone numbers, they get different jobs, so they have different insurances. And so that patient access department, it's their job to reconfirm all the things, right? And it's not a question like this, the question I hate. Has anything changed? Okay, let me see what you have in the system so that I can confirm that yes, I still live at 12345 Best Road, right? Because maybe what they have in the system is different. So it is less extensive to register an established patient, but we still have to do our due diligence. And when we have a new patient, let me just reiterate, we have to ensure that that patient is not already in the system. We don't want to have duplicate entry. So we want to make sure we verify the patient's information using a variety of data variables. All right. And when it comes to patients who have an insurance plan that has a co-payment, our contract with the insurance company says we collect the co-payment at the time of service. And I want you to think about this from a business perspective. Let's say the patient's copay is $20. Let's say we don't collect it at the time of service. So now we don't collect it at the time of service when that patient is right in front of us, and the end result is we have to contact the patient after they've seen us. Well, after they've seen us, we're sending them a statement in the mail. The statement costs us money. We have the paper, we have the envelope, we have the ink on the paper, we have the postage, we have the time that it takes to generate it. And so it is always best practice to collect the payment at the time of service. And a lot of places that I've been seeing lately, they have signs everywhere. Co-payment is due at the time of service. Here's the other thing, we got to make payroll every 2 weeks, right? So the more we collect up front, the better. And I know some people are saying, well, everybody doesn't have it, et cetera, right? But um, the best practice is to collect at the time of service. And that's why organizations, they take all forms of payment, except I don't think a lot of places are taking checks nowadays, because the checks sometimes do not clear. My mother used to call those basketball checks because they bounce back. All right, so the terms encounter form and charge master. Charge master is generally a term that is related to The hospital, we refer to it as the CDM, the charge description master, so CDM. And basically, for all the different departments that provide services to the patients in the hospital, they have a charge master of their services. So think about when you go to the hospital, you get a chest x ray, they have a charge master for the radiology department where if the patient has a two view chest x ray, the radiology department, when they're providing the service, can immediately capture the charge for the service. Why is this important? You learned about this last term or last semester, I should say, but it is important because they don't need us as coders to capture the codes for the chest x-ray in the hospital, right? So two terms I want you to be familiar with: hard coding and soft coding. You learned about this in the last class, but again, there's a lot of concepts that are repeating themselves. So soft coding means that a coder actually codes the service. Hard coding, it is coded into the system. So that department is capturing the charge. So the charge master has to be maintained. There is a charge master team or charge master person. And so as you're thinking about, career options post graduation, maybe you say, "Mm, I don't want to be a production coder." And so um I I would like to do something that involves coding, but I don't want to be day-to-day coder. So charge master could be an option. All right. So in the physician office, we have what is known as a encounter form or charge ticket or super bill. And if you've been to an office that uses these, you will as you continue in this program, you'll recognize it because it oftentimes has CPT codes on them. And after the encounter, the provider circles what the code is. And there's more that we can talk about that at a later date. But some of your smaller practices, you'll see that they're using a charge, uh, a super bill or encounter form. And what that means is that a coder may not be physically looking at the documentation to determine the charges. That's another story for another day. So here is an example of a charge ticket, and what you will see on there are either words or the actual CPT codes. Sometimes they don't put the codes on the encounter form, because the codes may change, but the words will stay the same. And so they do that for that particular reason. And then, I mean, gosh, there are like 80,000 diagnoses codes. So it is impossible to put all those numbers on there. Some offices will have the most commonly used numbers, but if they have a form, this particular format I like better, even though it's still not the best. Like, for example, you see diabetes on there. There's five categories of diabetes codes, right? So they would have to write the information in this little line, right? What if the patient has diabetes with cataracts, et cetera? All right, so this is a charge master sample. On the left, you see a service code, which is not the actual code like we code. To the right of that, you see a description. Then you see a three-character revenue code. We call them rev codes, REV rev codes. And this is a number that identifies essentially items grouped together by type. So, like you see how the radiology stuff starts with a three. Then immediately after that, you see um, a HCPCS level 2 code. And this is in this example. And I want to pause for a second and build a connection to your week one lecture. In your week one lecture, you learned about HCPCS having level 1 and level 2. So this is the level 2 code, the national codes. And so notice these codes start with a letter, and then you have the charge. All right, so insurance claims. So first things first, there are two types of insurance claims you need to know about. The CMS 1500, which is used for professional services, and then the UB-04, which is used for the facility. Okay, and so on these claim forms, if we are a participating provider with that insurance company, we do what is known as accept assignment of what they pay us as payment in full. So we may charge, and let me just go back. So, like, we may charge $674.50 for a service, but we may have negotiated with the insurance company that we'll take $400 for that service. All right. And then we also have what are known as out of pocket payment provisions. And this is basically the limits that are established for like the maximum of what patient has to pay up to a certain amount. And insurance is a whole vibe all by itself, which again, the program that you're enrolled in is coding specialist, and you're being taught reimbursement because there are some reimbursement concepts on the exam, but not a whole lot. All right, so managing the accounts receivable. Receivable means money we are receiving, right? So, in order to manage that effectively, we have to verify the patient's insurance. Oh, let me give you an example. So, it's January 2025, right? And let's say the patient presents an insurance card to you. Just because they got that physical card doesn't mean it's valid. What if they quit their job in December? And if they didn't sign up for Cobra, they no longer have that insurance. We verify it because the insurance company will tell us, yes, this patient is still active in our plan. So think about like car insurance. You don't pay your car insurance, you have a lapse in coverage. And so we have to verify the patient's insurance each and every visit, right? Some organizations do have patient financial counselors that will talk to patients about, all things insurance. Sometimes there are resources related to transportation to and from. The term pre-authorization is where we contact the insurance company in advance to get approval for the services before we provide them, right? It's not better to ask for forgiveness, meaning contact them after the service was provided. We also are capturing charges on a daily basis, posting payments on a daily basis. Remember, every 2 weeks we got to meet payroll, so we have to post payments, post that money to our checking account so that we can pay our bills. This also involves the claim submission and following up with the insurance company. Sometimes they are delayed for some reason or another. We need to find out what the deal is because we need our money. Give me my money. I think that was a TikTok video. I've clearly had too much caffeine today. All right. So the 1500 claim form, which is the claim form for professional services, when the patient registers, we get their signature that allows us to bill their insurance company. Now, just so you know, it's 2025. We're not typing out claim forms like we used to do when I started in 1992. And so when we're entering information into the system, accuracy is critical because we don't want to enter information into the system that is not valid. There's this term, garbage in, garbage out. So, very important to ensure that what we put into the system is accurate. One little thing could cause the claim to reject. And when it rejects, we don't get paid, but we still got to make payroll every 2 weeks. I know you're thinking, why do you keep saying that? Because you want to treat the organization's money like your money. So you want to make sure that what you're putting into the system is accurate. You want to make sure that you want to make sure that you do it in a timely manner, right? Because it's all a part of making sure that our revenue cycle remains healthy. All right, so the process of posting payments to the patient's account, we're going to grab those codes by looking at the documentation, right, and assigning the appropriate codes, what happened and why, when applicable, what was used, which is the HCPCS level 2 code. The encounter form is used to determine what the charges will be. And honestly, guys, a lot of times this information is in the system. So I think the book explains the information at the most basic level. On your job, they will train you on the technology that they're using, right? All right. So once the payments come in, if it's a copay, we're posting it at the time of service. If it is, we're getting paid, the um, the check, the paper check is posted, the electronic check is posted. But basically, think about this like I want to say like balancing a checkbook. It's just a bigger checkbook than we all have. So each patient has what is known as a ledger, and this is a term that you often hear in a physician practice setting. But the patient has a ledger. It shows every, well, this is in a hospital as well. It shows every date of service. It shows what we charge. It shows any credits for copay, and then credits for what the insurance company has paid us. And basically, this is a at a glance look at what is owed for this patient. And when we're calling the insurance company, we're calling them for a specific date of service that we're missing the payment for. That diagram is in your textbook, so be sure to take a look at it. This is another example of a hospital system, or I'm sorry, of a clinic system. So all the systems look different, but they have the same outcome. So um, don't allow yourself to be held hostage by, oh, it looks different. All right, here is a form that is called a day sheet. And this is how much we brought in for the day, right? So we had these 5 patients. The charges were $1,000. Of course, we're gonna have more than 5 patients, right? Adjustments. Our adjustments are like the agreement that we have with the insurance company, right? That the dollar amount that um, we accept as payment in full. So we subtract that dollar amount. So let's say we charge a 190, but we agree to accept 170. And right, so we deduct the $20, and because 20 and 170 is 190. This is not something you're going to see on a coding exam. So I just wanted to explain that. All right, so wrapping up this chapter, we definitely monitor and audit the revenue cycle. We have our internal processes that we have to do, but we also, the government has rules and regulations that we have to contend with, because we want to make sure that our revenue cycle stays what? Healthy, healthy, healthy. All right. So this chapter was all about revenue management, the revenue management process, new patients versus established patients in terms of how we register them. We talked about the encounter form versus the charge master. We talked about the patient to payment process. We talked about posting charges to accounts. And then we also wrapped up by saying we're monitoring this. And actually, we're monitoring this on a daily basis, because remember, at the end of 2 weeks, the organization has to make payroll. So we have to continue getting revenue into our system. All right. So this is all for this chapter. I'll come with part 2 lecture for the second chapter for week 2 of our outpatient billing and reimbursement course.